Good afternoon, everyone, and welcome to today's webinar. Our title for today's webinar is A Strategy Guide to Better Operational Performance in Less than 12 Months. I'd like to welcome today's presenters. We have three presenters for today. We have Chris Viro of Signature Performance. We have Lance Kylers, as well as Lori McBriarty. Chris Viros is the Chief Revenue Officer at Signature Performance. Chris has over 21 years of healthcare experience working with many of the nation's most respected organizations with a concentration of revenue cycle and health information management solutions. Chris has a very prominent role within the HFMA Region 8 chapter. I also like to welcome Lance Kylers, who is president of Connected Healthcare Solutions, which is a rural healthcare consulting company specializing in critical access hospital operations, hospital administration, physician practice management, rural health clinics, market analysis, and radiation oncology management. Lance has recently served as the administrator for the Bollinger Memorial Hospital in Texas. I'd finally like to welcome Lori McBriarty, who is VP for Career Step. She brings close to 35 years of healthcare experience, as well as healthcare information systems and product management to Career Step, where she drives the product of the company's offerings. Prior to joining Career Step, Lori served in various executive positions with companies such as XG Health Systems, WellPoint, Resolution Health, Kaiser, to name a few. So without further delay, I'll hand the call over to our guest presenters. Chris, I believe you're up first.
Great. Thank you, Nikki. I appreciate the introductions. And hello and good morning, good afternoon, everybody. Thank you for taking part of your day and sharing it with us. Between myself, Lance, and Lori, we're going to review and discuss a case study, a real case study that I'm sure you will find interesting and helpful. Some of the things that we're going to cover today are going to include challenges that hospitals are facing today. We're going to cover the approach to the problems and discuss how we address it operationally. We'll review some of the key areas and KPIs that were monitored along the way, as well as outlining the solution and discuss how to sustain the results. And then talk about questions and answers that you may have at the end of this as well. So now I'd like to turn it over to Lance Kylers, President of Connected Healthcare Solutions.
Great. Thank you, Chris. I appreciate that. And I want to thank you and Lori for everything that has gotten us to this point, because I'm really excited today about what we have to present based on this project and the white paper. We've all put a lot of time into it, and really, I think what this may become in the future is a model that can really help hospitals across the United States. So I want to thank you first and foremost for that. As we go forward today, I think part of what I need to do in my role is to be able to provide an overview of really what's going on in healthcare today, in addition to the role that our company played in the white paper. But as we look at it, there's really problems, solutions, and benefits, and that's really what came out of this collaboration. And the challenges that are faced by our hospitals is really, how do we improve access to care? How do we maintain our revenue? How do we be good stewards of the dollars that we have? And really to try to get a mentality of how do we thrive and not just exist or survive. I think there's a lot of organizational approaches, and that's really how Signature, Panacea, and Connected Healthcare got together. We really just brought our own specialty to the project, which ended up being a wonderful team approach. But we looked at the hospital operational analysis, we looked at revenue cycle management, we looked at the charge master and coding, and collaboratively we were able to do some really remarkable things on this project. Long term, what we hope for all the hospitals that we work with, individually or collectively, is that we always want to help decrease expenses where appropriate and increase revenue at the end of the day. So what's happening in healthcare? Everybody knows that healthcare is changing. We're going from an illness-based system to a health-based system. We've had a lot of issues with healthcare reform, and everything is changing dramatically. This next slide just basically shows you that we are in a curve. A lot of the critical access hospitals are cost-based. They're not rewarded on quality. There's an issue about being paid for low volume. And really, the market is shifting to value payments, continuity of care, systems of care. We're going to have to become much more IT-centric, and we're going to have to align our physicians as we go forward in this transition that we're currently in. And I hope everybody on the call understands we are in a transition in healthcare today. The next slide basically is just some information that a company called iVantage puts out, and I like to share it because I think this is a reality for a lot of hospitals. I think this references primarily small, rural, and critical access hospitals, that 82 hospitals since this was done have closed. Another 673 are in jeopardy. But it's not just the small rurals that are struggling. A lot of the larger systems are struggling as well, and you can see that if you look at any articles in Becker's or anything like that. We are faced as an industry with new delivery models and expansion of care, and what most people are aware of recently is the whole conversation about Walmart and Amazon collaborating. Now, obviously, it's good for them with all their employees if they're able to manage healthcare dollars, but for non-healthcare entities to be getting into the marketplace, I think that shows that there's going to be a larger push for collaboration, coordination, and consolidation of services. Our healthcare environment, we're facing reimbursement changes. Population health management is on the landscape and already engaged through chronic care management. We've got healthcare professionals that are working within the full scope of their practice, and a lot of our mid-level practitioners may be seeing expanded scope in the future. Our physician culture is changing, and most importantly, our consumer/patient expectations are changing due to the access of information that they have via the internet. The ACA has brought Medicaid expansion, health insurance exchanges, ACOs, and other initiatives. The government and commercial payers and consumers are all wanting a new system, and I'd like to just challenge everybody on the call that I don't think anybody wants to go back, maybe from a reimbursement standpoint, but from a consumer or payer standpoint, the writing is on the wall that there's a new system and everybody wants to move forward. And as hospitals, if we don't work to change and adapt to that system, I think we risk obsolescence. Now, the current rate of healthcare spending is unsustainable, as we all know. I like this slide because when you look to the right of the slide in the orange area, just in the interest alone, you see that by 2050, compared to where we are today, over the next 30 years, there's going to be a significant rate of change with the reimbursement that right now our system can't sustain. The system changing really reflects us in a lot of ways, and I wanted to just have something fun on the slide for you, but if consumer prices had risen as much as healthcare since 1945, a dozen eggs would cost $55, a dozen oranges would cost $134, and a gallon of milk would cost $48. And of course, again, going from $2.6 trillion in healthcare spending to $4.6 trillion in healthcare spending in 10 years is unsustainable. So that really brings me to the point of we have to have a conversation about denial to just keep going around in the circle, or risk the reality of potentially going off a cliff if we don't have a plan in place. And I think this is because we are facing a lot of leadership challenges. I think we've got severe limitations to the access of capital. We have increased burden of remaining current on the onslaught of healthcare changes of volume to value, the payment methodologies, the regulation overload that we're having. I think everyone is struggling with the difficulty of the recruitment of providers, managers, and staff. I don't know if you just saw recently in Becker's, but I believe it was Tenon is now looking at paying $25,000 sign-on bonuses for nurses, which long-term for anybody, I don't know if that's sustainable, even the big systems. But I think we're facing increased competition. I think we have a requirement that our information technology has to be on par with the large systems. And we have a lot of hospital governance members that just don't have the background and training in a very advanced system. So where are we going with our future of healthcare? I think it's going to be a narrow, steep road, and I think we have to proceed with caution. I think the realization that we're coming into is that the current volume-based fee-for-service system is unsustainable. The days are numbered. It is being replaced by population health models. The payers are transitioning to population health models, and even to that point, a lot of the large commercial insurers now are paying for chronic care management because they understand long-term that's going to save them money. And then medical providers and hospitals that fail to transition, again, really risk obsolescence or potential failure in the future. And so we always like comforting lies more than we like unpleasant truths, but I think part of what you're going to hear today on this conversation is really the truth of some of the things that it takes in order for our hospitals to be successful, starting with operational analysis, going through a revenue cycle revision process, and looking at the charge master and coding to make sure that we are working our system the way that it should. Our old systems, cost wasn't a consideration. The doctors were independent. We were on a sickness system. The new systems, we've got to get our costs down. A lot of our docs are employed. We're looking at a wellness system, and we're looking very much at an outpatient-driven system as opposed to an inpatient-driven system. So our healthcare reform, when we move from volume to value, most of you have probably seen this, but the triple aim, better patient care, better health for the population at better cost, is really going to be a resounding gong that continues to be drummed into us as we move forward, just because we are going to have to focus on the health of populations, not just individuals. We're going to have to increase our patient care experience, and if anybody knows about experience with customers, going back to an earlier slide, Walmart and Amazon have an awful lot of experience in that we might learn from. Not that I'm advocating for that, obviously, but I think that's just a sign of the dynamics that are happening within our healthcare system. And so what does this healthcare reform mean for our hospitals? I get calls every day from hospitals that are looking for direction. They need help with clinically integrated network. They need help with coordinated care and navigator programs. Most of the systems are very primary care driven. They have issues around quality reporting and database management. Our consumers, the new patient has a higher expectation than patients did even 5 or 10 years ago. We're having to talk about market share. We're having to balance the change in the reimbursement system. And again, we have accountable care organizations out there that are changing the landscape of how we deliver health care. In the future, I think it's really going to be based on that old adage of quality and service over cost equals patient value, and I think that's going to be the life-saving line that we are able to throw to the hospitals through a collaboration like we were able to do on this project. And so, how do we succeed going forward? I think we have to demonstrate a top-down commitment to high-quality care and organizational efficiency. I think we have to require that objective measures and benchmarks are used to gauge clinical efficiency in the services provided. I think we have to ensure that our clinical reporting programs are in place and working effectively to monitor our quality measures. And up to this point, I think we've done very well in gathering data. We just haven't made that transition into reviewing that data and determining how that's going to impact the majority of the patients that we're treating. I think we also have to help ensure the viability and improved operations of the independent hospitals that are serving multiple markets and multiple service lines. I think our intervention should include a review of staffing, finances, operations, and processes, which is what we did in this white paper. And at the end of the day, hopefully the results are going to be realized cost savings to hospitals, including hard and soft costs, with the expectation of continued operational cost savings in the future, all of this being based on high quality care. What we can't continue to do is operate our hospitals like we did 5 or 10 years ago. I think we have to identify and focus on our functions that are important to the operational success of the hospital, including staffing levels, benefit costs, things like that. I think we have to assess our facility performance based on our relevant measures and data. Leadership has to be involved, and department managers have to be involved in the operational analysis process. And I think we have to push ourselves and each other to continually pursue improvement in everything we do. I think we also have to look at our structure. We have to review measures including the organizational structure, the services, our providers, our demographics, the traits that got us to this point. I think we have to review measures that are goal-directed based on statistical benchmarks, not just guessing at what those might be. I think we have to have specific action plans and steps related to our operational analysis so that we not only identify it, but we're able to actually go through and implement it. And then I think finally we have to have outcomes. We have to be able to show that what we are doing makes a difference. And that's one of the things in partnering with Panacea and with Signature that I was really pleased with on this project is even though we all brought a little bit of a different measure to the table, the end result was wonderful. And I think really what we did is utilized a team approach with our partner hospital to review their operations, their revenue cycle management, their charge master and coding so that we're not looking at a glass half empty, we're looking at a glass half full. I think our hospitals have a wonderful future in front of them, but I think that the key to that is being proactive as we move forward. So with that, Chris, I'd like to turn it back to you.
Great. Thanks, Lance, and nice job. I think that really gave a good overview of what's going on in healthcare and in our industry and what some of the challenges that hospitals are facing out there today. So what I'm going to do is get into a little more of the revenue cycle on the HIM side of what we've done in the case study that we also incorporated into a white paper study that we did. So the first part of this is I'm going to touch on the pre-work that we did in order to put together an analysis and overall recommendations, which also included on-site evaluations, visiting with the hospital and the staff. And that drove the solutions that we wanted to present, and then how do you implement those solutions and the recommendations that you come up with. And then finally, we're going to touch on some of the solutions as well. So in looking at the pre-work and the pre-analysis, the first step was to gain access to the hospital system. And the hospital allowed complete full access into their patient accounting EMR system so that we could really conduct a good pre-analysis perspective. In approaching that, we wanted to make sure that we also were able to dig into the financials, reporting, as well as how they use the system to provide indicators as to where some of the opportunities within a hospital may reside. So some of those reports that we analyzed would include cash receipt summary and detail. We reviewed detail ATBs by financial class, revenue and receipts by financial class, revenue by payer, self-pay reports, and other aging reports. So we did a lot of that pre-work in the system and pulling reports from the hospital. The pre-analysis that we did identified a few key areas that would also warrant additional work and lead to the fact that we were recommending that we do an on-site assessment. Some of those key initial findings included that government plans and claims were aging and recovery rates were lower than what is normally seen or what we typically would see out in the market. This was leading us to want to look at their billing and follow-up processes and also an indicator that there could be a need for billing support, additional support and or training of staff that they have within the facility. There was also significant AR that was aged and continuing to age. Much of this AR was aging to a point where it was becoming unrecoverable. In fact, 40% of the AR dollars were, in this case, over 365 days and would yield a low recovery rate based on timely filing restrictions. This also represents 57% of the total number of accounts that they had, so there was quite a bit of volume that was aging. Unpaid claim balances were aging beyond timely filing without additional adjudication based on the percent of AR in each of the aging buckets. Spending resource, which was causing additional talent to be pulled towards that old AR, and new AR was continuing to fall into, again, the higher aging buckets. We were able to see that large volumes of reimbursement were also posted in what we call a miscellaneous category. So that was a little indicator, a little red flag in our pre-work that was causing us to think that we needed to do a little more digging into that. And then we also noticed when we started looking at self-pay that 56% of the self-pay was aged over 2 years. Another 10% was aged between 1 and 2 years. So with the amount of that AR still on the books and aging, it was a clear indicator that we needed to get a better understanding of how they were handling their self-pay and their process there. Also, because the AR was aging on the reports we were looking at, it made sense to look at other areas that included registration, credentialing, coding, claims edits, processes and rules, clinical documentation, as well as denial management, all things that lead into other aspects and feed the revenue cycle. So we reviewed the initial pre-analysis with the senior team over the phone. That was an interactive conversation, and it was determined that we wanted to provide an on-site revenue cycle and HIM review in order to give them a fresh perspective on what was happening in the front, the back, well, really the front, the middle, and the back end of the revenue cycle. So we conducted the revenue cycle review to include all of the areas that you see here: the pre-registration, pre-auth, point of service, insurance billing, follow-up, insurance training, HIM, AR, self-pay, and then finally the revenue integrity areas. So after conducting the on-site review, we were able to identify additional findings from spending some time there with the facility. So I broke those down into 2 areas, really, HIM and then the rev cycle. Starting with the HIM, one of the things that we found is that we needed to remove as much from the coders as possible that was not really directly related to coding. So we saw that the coding staff had other administrative responsibilities, and that was really taking them away from actual work that they needed to do on the coding side. We also noticed that they didn't have any auditing in place, formal auditing, so we were looking at, okay, we need to figure out how we can get a coding audit in place there with the staff. There wasn't a good method for tracking coder productivity or quality, so this was something that we thought was imperative to understand, okay, how well are the coders doing both from their quality perspective as well as getting the actual work done, and might explain some of the reason for some of the denials that we saw on as well in our analysis. We also found out that it has been a few years since the facility had done a complete charge master review, and this is where we would recommend Panacea also on this call to provide a complete review and update the charge master. So again, leading into the partnership that we had for all 3 of us. So in looking at the revenue cycle and some of the findings that we uncovered, both in the pre-analysis as well as on site, it was confirmed that we needed to standardize processes and procedures, and we really needed to document what some of those procedures are. And I would say throughout the whole entire revenue cycle, the front, the middle, and the back end. But I think especially in the front part of the revenue cycle where we were looking at the pre-registration, registration, and eligibility, how could we strengthen processes for the hospital in order to improve that function in that overall area? It was also determined that the charity program should be managed by the financial counseling team and led by a strong manager. Those policies also needed to be reviewed and looked at for consistency. In looking into the insurance billing, in that area, we found that a few simple adjustments could assist in driving additional revenue significantly, as well as improve work processes between the departments. So this would include focusing staff on their specific functions versus managing several tasks. We also wanted to implement a billing tracking process to increase the productivity. Staff also needed additional insurance training or insurance billing and follow-up training, and that became clear as well. On the system side, we determined that claim edits needed some work. They weren't being utilized effectively, and the way they used the system needed to be improved as well. So that was another takeaway that we wanted to bring to the organization in order to help reduce rework and reduce denials at the same time. So the solution that we had is, and what we wanted to present to the client is several areas here. So we began by letting them know of the key areas in an interactive conversation, and ideally focus on improving cash quickly within the facility, and do that in a way where it would be sustainable cash and a program that would continue to maintain positive results. We began by providing needed management and direction for the existing staff. So we're providing the oversight now, the training and the management of that staff. So they reported directly to our organization, and were able to provide that that leadership. And at first, I would say the staff was not as happy with that as you would have thought, but in time, that was something that they really valued, because they saw that they're getting much needed training, and it was making them stronger employees. The goal was to really also focus those teams by function, so that we could get them in their swim lanes, as you will. We also provided additional remote staff behind the scenes to assist in jumping on that old and outstanding AR to ensure proper follow-up in order to get that cash flowing quickly. And that would allow the current staff within the facility to focus on a lot of that newer AR that was coming into their system. Utilizing the system to a greater extent was also a part of improving the process. We wanted to reduce the workload on the back end, make sure system edits were in place and working properly. We also took the claim edit management up a level and away from the billing staff, so that we could manage that appropriately, as well as with the teams there. A payment integrity program was built to ensure that claims were being paid accurately and correctly. And that's an important part. You know, when the payers are paying them and the cash comes in the door, that's great. But was it enough cash? Was it the right amount of cash that should be coming in on that particular claim? So in order to make all these changes sustainable and new processes and procedures in place to continue to drive the organization, we documented all of those processes throughout the entire revenue cycle. So we wanted to make that repeatable, so that as a hospital had staff turnover, we didn't have to start from scratch. We had a process that we could deploy and implement and train new staff members as they came into the facility. The hospital also was tracking metrics and had several in place when we got there, but we worked together in conjunction as a partner with the facility in order to develop additional KPIs, incorporate them into a dashboard so that we could continue to track the ongoing performance within that facility. So in the end, what we ended up with is a cleanup of processes, a whole documentation of that revenue cycle process, providing management oversight to the staff in the entire revenue cycle, providing additional billing and follow-up behind the scenes, as well as working with that staff. And all of this equated to significant cash increases for the organization. And you may be wondering, how much did that really impact the system in the hospital? This is the result that we saw after 12 months. And in working with this facility, by employing the practices that we just discussed, and with Lance's help as well as with Lori's help, we saw meaningful results. This represented nearly a 300% increase in cash. And I don't care if you're a small hospital or a large hospital, whenever you take that amount of cash and you add it to the bottom line, that will make a difference. So what does that do for a facility like this, or any facility? It allows you to recruit physicians, or better physicians, or different physicians. It allows you to look at upgrading equipment or systems when you may not have been able to do that before. So those are all key benefits that this hospital was able to see as a result of some of this, and along with what Lori's going to talk about next and what she was able to do with her organization. So Lori, I'd like to turn it over to you.
Great. Thanks so much, Chris, and welcome everybody. And you know, this is really impressive, right, as we go forward and look at that cash collections. And I think that this is just exciting to see what we can do after we're not running over the cliff, as Lance gave us a view. So I'm going to actually take a little bit of a change and take us into kind of things all charge master, if you think about that. In our organization at Panacea, we really position the charge master as the fuel that really runs the revenue cycle engine. So let me walk you through these challenges that you see on your screen today of what the organization that we're referring to today was kind of up against. You heard from Lance and Chris that they really wanted to improve their financial performance. And you also heard their charge master maintenance was overdue. So this was both in clinics and hospitals, and we know that that's really critical, and you'll see a little bit more about that. And they also wanted to manage some of the complexities within their managed care contracts. Now, not to say they had the most complex managed care contracts, but they did have some complexities with percentages and actually issues binding all their contracts, so we'll talk about that for a little bit. And they also wanted to focus on rational and defensible pricing. I think those of you who are in the HFMA world and the revenue cycle side, you'll see all of the conversation I'm sure you've seen about rational pricing. And so this organization really wanted to start to take a look at that as they improved kind of their performance overall. So let's talk about the charge master for a minute. And I mentioned before that we view that as the fuel that really runs the revenue cycle engine. So I think you all know that the charge master is like made up of, depending on the organization, it could be thousands and thousands of lines of information, or it could really be, hundreds of lines of information. But the key is that it's really key with all of your procedure and revenue codes and descriptions. And we know that these things change with CPTs and CMs and HCPCS and PCS codes. They all have different dates and changes that they change every year, and how CMS is making changes with CM and PCS codes. So it's really essential to maintain your charge master, because everything really flows. If you think about that of the hub, that everything flows from your charge master. And many times it can be impacted by complicated systems. Even though in a smaller organization you may have one system that's all contained, there still may be some things that are kind of sneaking by. If you think about your nurses on the floor are actually trying to make sure, are thinking what they're collecting for charges are making it to the bill, and if it's not in the charge master or from the lab, it's not in the charge master, it doesn't get billed. It's kind of like on the documentation side for coding, if it's not documented, it didn't happen. Same kind of thing if you think about your charge master. The charge master can also be impacted by happenings in your organization. Are you implementing cost-sharing models, is what Lance alluded to? Are you doing in the middle of a software conversion? Are there an acquisition? Are you been consolidated? Have you been merged? So those are the kind of things that really impact your charge master. Let's just take a look at what we did exactly for the charge master. So what we completed, because everything seemed to be so far behind, we completed a line-by-line review of the charge master, both from the clinical side and clinic side and also from the hospital side. And when you do that, you want to make sure you're really looking for those missing or incorrect codes. So as you all know, like I said, is if the code changes, it could cause you could cause you to have a denial. It could also cause you just not to have anything paid because you've got the incorrect code. Or if you're missing a charge. So say there's a pharmacy charge or a laboratory code that's been changed that hasn't been reflected, hasn't been updated in your charge master, you may think that department may think they're charging for it, but they may not. So this is a critical piece as you look to improve in your organization, is to really update your charge master. We then went in and were contracted to make those updates in the charge master, but this is something you want to look at like at least every year at the very minimum, is to make sure your charge master is healthy and up to date. And so you can see what the organization was able to see was that almost not immediate, but resulted really in a 14% improvement just by making those changes in the charge master. So that was one step. And again, if you think about your charge master as key, the other things I'll talk about are really related to that. So if you want to start to analyze your pricing, so we talked about that, and Lance referred to, our consumers are much more educated, and there's a lot of talk about transparency out there. So really, consumers and boards are all very, very, very what's happening with your pricing. So you want to take a look at your pricing. You want to start to look at what's your physician charge fee schedule. You want to start to think about cost data. In healthcare, for years, what we've always done is every year we increase it by 3% or 6% or whatever your mathematical equation happens to be. But what they can do is really give you some inadequacies. So you may have things that are really raised much above where they need to be, and things that are maybe not, or should be lower, should be higher. So you really want to look at some optimizing of your prices. We applied some optimization features. You want to also look at what-if scenarios. So what if I raised a price here and I lowered a price here? What is that going to do to me? And you really want to compare your pricing with peers. So you want to look at, and we'll talk about this a little bit more, but you want to look at your local peers, peers of your groups, similar hospitals. So you really want to be able to slice and dice it to look at, what's happening with my pricing as we move on. And another key piece, of course, as your pricing are your managed care contracts. So when you step and think back and you start to see the picture, hopefully that we're creating, is you have your charge master in the middle. It contains all your descriptions and your prices. We got to look at those prices. Then we have to look at our managed care contracts, and we analyzed the managed care contracts, and we looked at the contracts for allowable rates. So a good example to think about, just to do it simply, is if your allowable rate from your contracts is $500, but in your charge master you're charging $275. Just as an example, that's actually some revenue you may be able to make up. And then you want to really look at that, find those, look deep into your managed care contracts. I would suggest that you actually also find those contracts. I know many years ago when I worked on the West Coast that we had binders and binders of contracts. Sometimes as you have staff turnover, it's challenging to find where they are. But even if you don't have a contract system, which I don't think many people do these days, but really get all those contracts gathered up in binders so you know where to find them, so you can actually do that analysis. And we did that analysis with our organization here, and you can see we saw an immediate return on investment of about 41% as we really were able to make some changes to the contracts and tied to the charge master and pricing. Kind of all balled up together. So we talked a little bit about pricing, but I think I wanted to step back and say, if you want to create strategic or defensible pricing, you want to make sure your prices are rational. So a good example, and a thing that's easy for all of us to think about, is in the pharmacy area. So we've all seen the news where, a hospital's charging $200 for an aspirin. So I think that's just an example and something that's blown up, but that's really what we want to go back to when we look at strategic pricing is, what our prices are based on cost, and we can explain them, and I would like to say, to your neighbors. Like if you had to, you could explain your prices in your hospital to your neighbors, and then really look at, is there some other area where you can increase, and like we said, make sure you look at your contract. So tie all those together, and then really develop a plan, because after we've done 3% or 6% increases time over time for the last few years, you really can't just make dramatic changes. So say you competitively looked at, and your competitors in your area are 10% above your costs. They're charging 10% more. You can't obviously just raise all your prices 10%. You really have to look at what makes sense, and you want to make sure that aspirin, as an example, doesn't cost $300, now it costs even more. So you really want to look at what can I decrease and what can I increase, and then you want to set in place a plan. So we worked with our client and really set in a plan in place that will happen over the next 3 to 4 years, and they'll be increasing some prices and decreasing others to really get themselves in line. And really, you want to use an expert in this process, and you can see that we saw our ROI in our what we call zero-based pricing is really a 15%, which is really dramatic, but I think there's even more that will happen over time. And you really want to use an expert to help you, so you can actually have that experience from others who've gone through this with other places, small and large, kind of over the sense of time. So I think with that, Lance, it's time to turn it over to you to get a quick summary for our listeners. Sorry, Chris, it's going back to you.
No problem, Lori. This is Chris. Thank you, and nice job. So, a lot of you guys that maybe on the phone know me, and I'm kind of a storyteller. So now what I wanted to do is get into a review of this and what made it so successful. Aside from the fact that 3 organizations were partnering together to really provide an ultimate solution to this facility, which I think was amazing. The 3 organizations worked really well, and the idea was to benefit the organization. by increasing cash, reducing redundancy, increasing efficiencies overall. I wanted to take a step back and just look at why was this so successful and what made that successful. And I think there were many factors that entered into it. And the first indicator, the first thing was that the senior leadership team, first of all, they identified a desire to change and they wanted to improve. They knew that there was some problems and needed to make a difference. And in our healthcare environment today, we want to make sure our hospitals are thriving out there so that we can provide that valuable service to our patient population. So I think that was the key thing. They identified that. Secondly, there was complete support from the CEO and CFO, and they really made a commitment to change. And I recently heard a story that I'll share with you. It was about a father and a son having breakfast, and they were eating ham and eggs. And the father was teaching his son about commitment. He told his son to look at the plate of ham and eggs, and he said, "Son, you see those eggs there? The chicken that produced those eggs made a contribution. Now look at the ham. The pig that is responsible for that ham made a commitment." So the CEO and the CFO in this case, they made a true, honest commitment. In a lot of our hospitals that are governed by a board, in order to convince the board to make change and to buy off on change, that's a difficult task in a lot of situations. But I think because the CEO and CFO of this organization were so committed, they were able to convince their board that change needed to occur. And it may involve bringing in partners to help them. And we see that especially in rural towns where there may not be some board members that are open to outsourcing as much. But getting the board support was paramount, even though it wasn't easy. But they were able to get that. And so the board also fully supported this endeavor and started to understand that maybe the staff that was in place didn't have all the necessary skills to accomplish some of the change that needed to happen. By improving their cash and the overall result of this, it would allow the hospital to invest in other ways to improve its service in the community. And I think that was the key endeavor that we all wanted to strive for. So when I look at some of the other areas that we wanted to talk about, and just as reminders, one of the key things is we want to make sure that the hospitals and the industry is focused on quality outcomes, and that's really what should matter. How can you provide quality service and get it done efficiently so that it's in a cost-effective manner? You want to ensure that a complete operational analysis will help determine where those biggest opportunities are. Sometimes it takes a fresh perspective to look at those things. So that was a piece that I think worked very well within this particular case study. You want to be able to improve that cash flow, and in doing so, don't forget about some of the things that also impact and roll up into that cash flow, such as your charge master, as Lori pointed out. Seek those experts that can help you where you may not have that expertise. Reminder to look at your managed care contracts. Find those, review those. If they haven't been looked at in a while, we would all encourage you to take a look at those and make sure that those are performing the way they should. There's also a lot of articles that articulate some of these things, and HFMA is an organization that I'm very big in and have been a part of since 2000. And I use that as a resource to understand what's going on in healthcare, and they publish a lot of articles, and something that is a good resource for all of you out there as well. So in a nutshell, we're in a world of chaos, and healthcare is challenged in a number of different ways in different areas. So we need to seek creative ways to allow our hospitals to thrive today versus struggling, so that we can provide that valuable service to the patients that we serve out there in the market. So now what I'd like to do is turn it back over to Nikki and have her open it up for questions.
Perfect. Thank you so much. What a great tag team effort here. Before I take our first question, I just want to remind everyone to type their questions into the chat panel located to the right of your screen, and we will tackle as many as time will allow. I will address the first question about getting access to the slides, so no need to wait. You can get access to the slides right now, you can simply expand the handouts section located to the right of your screen, and you'll see that little PDF icon where you can get access to those slides. All right, so the first question came when you first started talking. I believe it was you that was speaking, Chris. When you first started sharing the case study, there were two questions actually. One is asking if they could get a copy of it by any chance. Do you guys have a tangible version of the white paper case study that you were referencing?
We do. We published the white paper, and that's something we can email or mail. We would just need the information on where to send it.
Awesome. Perfect. Okay, and obviously we have captured everyone's information, and we'll pass that along. And then we had another question about, is this being recorded? Absolutely, it is. So you guys will have access to this replay link when we conclude. Another question that came in, and again, it was at the beginning when you started talking through the case study, were there any challenges gaining buy-in for full system access? And if so, how did you overcome them?
Yeah, I can tackle that one, and then Lori and Lance, if you want to chime in. If you'll also advance the next slide, Nikki, you'll see our contact information should be there. And so I would encourage anybody that wants to reach out to us as well, you can do it that way, and we'll also make sure we can get you that published copy of the white paper. Yeah, gaining system access, was a little bit of a challenge in this case. Honestly, Lance was a big help in that. Also, he had a relationship with the senior leaderships to begin with. Once we were able to convince the CEO and CFO of what we were wanting to accomplish and how we were going to tackle that, I think that became an easier task. But at first, it did require a good understanding that they needed to understand really what we were wanting to accomplish there. From a technical perspective, it was easy. We were able to gain access, and they had resources that were able to provide that access fairly well.
Yeah, Chris, this is Lori. I would say the same thing that, we do that as part of our normal services, so we do gain access to people's systems, and so we have full BAAs, et cetera, that if needed, that we need to execute. So it's really about making sure your senior leadership is bought in to get that done.
All right, perfect. Thank you. I'm actually looking, and it looks like we've actually exhausted the questions. So as I close, if there are any last-minute questions that you can think of, feel free to just shoot those on in, and I'll shoehorn those in before we reach the top. Well, the middle of the hour is where we started. So I do want to thank everyone for taking the time out of your schedule to participate in this webinar. And as you exit, you will be prompted with a survey, and we would greatly appreciate you sharing any feedback about today's event, as well as what type of topics you're looking for in future webinars. You'll also get a chance to let us know if you'd like to hear from Signature Performance or Connected Healthcare or Panacea on the services that they may be able to offer to your team. So again, thank you to all of our guest presenters, Chris with Signature Performance, Lance with Connected Healthcare Consulting, and Lori with Panacea, a career step company. Any last minute parting words, guys?
Hey, Nikki, this is Chris. I just saw a couple of questions that just popped in. I don't know if you're seeing the same thing here, but one of them was, how often should a hospital have a rev cycle review or coding review? And I would say annually is a good measure on that, depending upon what's going on. As a common practice, to have a good, thorough revenue cycle review, and that's because things are changing so quickly within our industry. The other one that I just saw, and I'll turn this over to you, Lance, is this hospital apparently is a critical access hospital. I'm just wondering, have we provided this kind of work for small hospitals? So I'll let you jump in on that one.
Thank you, Chris, and absolutely, yes, we have. One of the things that was not in the slides, but I wanted to share during the Q&A, was that in this particular instance, the benefits of this partnership going forward have been completely apparent in that they just recently received their most recent cost report and audit, and from one fiscal year to the next, the operating loss in the organization decreased by $2 million. And so I think that just goes to the point, Chris, that when you're able to come in and look at the operations, look at staffing, look at benefits, look at contracts, look at your revenue cycle, look at your charge master and your coding, you really can have a huge impact on the organization. Now, obviously, there are challenges with every organization. There's politics in every community, but I really think that's where the beauty of this partnership comes in, because all three of our companies come at it from a little bit different angle, but we're all looking at the same goal, which is to do the right thing for the hospital. So absolutely, small rural is something that this can work in, but by that same token, Chris, I would also say in the larger hospitals, potentially there could be even more benefit there, not only on an operational analysis, but from the standpoint of revenue cycle and the coding and charge master benefits.
Yep, that makes sense. That's all the questions that I saw. I just wanted to say, unless any others popped in that you're seeing, Nikki, I just wanted to say thank you to everybody that attended our session today, and if there's anything we can ever help with, let us know.
Right, and I think, this is Lori, just to add, I think we are sending a follow-up email with a link to the case study, so for those, so you don't have to type so much, but we are planning on sending that out afterwards.
Perfect. All right, folks. Well, thank you again for taking time out of your day, and we hope to see you online in the near future. Have a great afternoon, everyone.
Thank you.